Hello. It's really a fantastic pleasure and honor to be here with you on this second annual Women's Heart and Vascular Symposium. And what a thrill to be giving this topic as a lecture that has been chosen for a keynote lecture, Gender Differences in PCI, Percutaneous Coronary Intervention Outcomes. It's important for you to note my disclosures specifically with multiple device and drug manufacturers that may have something to do with gender differences, but honestly, there's no real direct conflict on any of the data that I'll be presenting to you. I think it's really, really important to think about the differences in the characteristics of myocardial ischemia between men and women. And it's really also important to understand that women are not small men and that we have different presentation, different triggers. So I want to just kind of a little bit go through that because the differential diagnosis when you're seeing myocardial ischemia in a woman may be very different than that of a man. And although for the most part, we do see in men obstructive coronary disease and atherosclerotic plaque rupture or vasospasm, in women, we are seeing a multitudes of different kinds of presentations, specifically in plaque erosion rather than rupture, although they do also have atherosclerotic plaque rupture. Really, really important understanding of non-obstructive epicardial coronary artery disease, where they do present with either ischemia or even infarction, microvascular disease, obstructive disease, just like our male colleagues, and then a really important entity called Takotsubo cardiomyopathy and spontaneous coronary artery dissection, which is really, really under-recognized until most recently. It's also important to understand that the triggers could be very different for women. And while physical triggers are there, just like our male colleagues, emotional, psychological, and mental stress do play a very important role in women. And the lesion morphology and the vessel characteristics are also different between men and women. So when we see all of these important differences in our presentation, anatomy, triggers, and of course, importantly, the pathobiology being somewhat different, why is it that we're not really looking at these gender differences with a much, much clearer lens? Because our revascularization guidelines are the same for women as they are for men, despite the fact that women represent a very, very small, maybe a quarter, 25% of all of the PCI or revascularization trials. And as such, I think there's an important issue to really discuss. And it's very, very important to, at the very least, every paper be required to present the gender-related differences. Well, let me tell you why I think it's important. Because women, despite their, if you adjust their risk factors, and here's a really, really great registry, the Sweetheart Registry, which is pretty much everyone in Sweden, and they don't lose a single patient, 130,000 patients hospitalized, 40% being women, and 48,000 of these patients with an acute myocardial infarction in 11 cardiac care units. And the thing that really, really upset me when I saw these data is how women are unfavored. I mean, pretty much you see that the reperfusion treatment and antiplatelet therapies, whatever it is, all of these important issues regarding beta blockers, ACE inhibitors, aspirin, statins, and also antiplatelets are favoring men. And you see that right here. But the most important one is where we know we can make a difference in the longevity of our patients is reperfusion treatments for both STEMI and non-STEMI patients, favoring men, not favoring, disadvantaging women. And this is just a really, really important understanding that we must, absolutely must understand the differential impact that we're having by undertreating women by ignoring their symptoms and not understanding the pathobiology, and that a lot of the future trials have to focus in making sure that we absolutely understand what's going on. Just this past week at the American Heart Association, Harmony Reynolds, through a grant from the AHA, looked at the myocardial infarction with non-obstructive coronary artery disease in large numbers of patients, evaluating optical coherence tomography in multitudes of these vessels that were non-obstructive. And very important, in 75% of the cases where there was myocardial ischemia and myocardial necrosis and edema on MRI, there was atherosclerosis. So we absolutely must have a better understanding on how we take care of women who present with myocardial ischemia, who have symptoms, and they can no longer be ignored or disadvantaged regarding diagnosis and treatment. But let me go into a little bit of what do we know as far as revascularization types in women. In the very, very distant past, back in 1984, when the CAS study and the VA cooperative study made CABG the gold standard for patients with multivessel disease and left main for revascularization versus medical management, there were only 90 women in those trials. So a really, really small numbers of women enrolled in those trials. And so the data was really very much scarce in understanding the outcomes of women. In the most recent study of PCI versus CABG in left main disease, I had the honor of being part of the executive committee of the EXCEL trial, and we made sure that in a pre-specified analysis, we would absolutely look at the gender differences. Really important when you make a choice of a revascularization treatment, especially in left main disease, that we understand gender differences. In this trial, 1,905 patients were randomized to PCI using the everolimus-eluting stent DES versus bypass. Patients were followed all the way to 5 years, with the primary endpoint at 3 years of hard endpoint of death, MI, and CVA. Really important to take a look at the differential impact of men versus women. And while we only had about 23% of female patients, only 441 of the 1,900 patients were women, we again saw very similar to other trials that when women present for their revascularization, they're often older with more hyperlipidemia, more hypertension, more diabetes, more congestive heart failure, more anemia, and even more so with mitral regurgitation and a lower creatinine clearance. The family history of premature CAD is more often seen in men. And then lastly, here in this trial, men had a lower ejection fraction compared to women. We know that women often have normal ejection fraction and heart failure with preserved ejection fraction. Importantly, anatomically, there were also really important differences. And in this particular trial, women often had more of a simpler anatomy, with a syntax score being lower in the extreme ends. And the higher syntax scores were more often seen in men, the highest ones. Women often had osteal lesions. This is really an important one because they don't do very well with PCI. Patients who have osteal lesions do not have a great outcome as just mid-shaft or proximal lesions. And then, of course, the distal lesions were more often seen in men. What we found in the individual 3-year outcomes, in the overall outcomes, you can see the important male CABG in red, male PCI in green, female CABG in beige, and female PCI in blue. And what you're seeing is the differences, completely lots and lots of differences. We're not really powered for this analysis because remember, only 22% of the patients, but the one that really is striking is the male PCI versus the male CABG doing really different, and women also having higher event rates in PCI compared to CABG. And interestingly, despite this differential, you can see that the overall revascularization rates are higher in women compared with men. And when you look at death, without a doubt, the highest death rate was evaluated and seen in women who underwent PCI. So what we did see is that the rate of the primary endpoint of death, MI, and stroke at 3 years was numerically higher in women treated with PCI as compared to women treated with CABG and men treated with either strategy. So really important analysis from that particular study. Here is some study looking at PCI patients, especially for women compared to men. Once again, we start to see a very different story of women presenting with much more complex disease. This is individual patient data from 3 all-comers DES trials that are listed up here. They were pooled as a patient analysis. And of course, they looked at the protocol mandated follow-up to try to understand the restenosis rates. Very important, as you can see, the differences in age, diabetes, obesity, and hypertension in women. And of course, very important to note that these differences had to be corrected for. If we look at the sex outcomes, and when you look at an analysis that actually corrects for the baseline risk of these men and women, you start to see that we are crossing the line of unity pretty much on everyone. The p-values not being significant at all whatsoever, and we're not seeing the differences. And in fact, when you look at binary restenosis and on revascularization in terms of in-stent late lost and binary restenosis, they're very similar once you correct for their baseline differences. We also took on the very similar idea of saying, well, of all of the drug-eluting, early drug-eluting stents, newer drug-eluting stents, and bare metal stents, we always had only about 20% of the population in women. In what way can we understand that as we move from bare stent to early DES to newer DES, that we're actually seeing the benefit across the board in our female patients, the way we have seen it in the mostly male patient studies. So as a result, through this initiative of WIN DES collaboration, we brought 26 randomized trials, pooled all of the data with using patient-based individual patient data. Of the 43,000 patients in these trials, let me go back, of the 43,000 patients in these trials, only 26% were women, but we now had access to 11,557 female patients. What we found very importantly, and we were relieved to see, that as we went from BMS to early DES and newer DES, we began to see a really great outcome in terms of death and MI and in terms of definite in-stent thrombosis overall. And this is really important. And of course, TLR, as expected, we're seeing a very important differential of enhancement over bare metal stents in women. And as far as death and MI and definite in-stent thrombosis, we're starting to see that early versus newer DES is much better also in women, such that this newer next generation DES are also reducing the death and MI and definite improbable stent thrombosis in our female patients. This was really important to see. And then, of course, importantly, we looked at those women who had complex or PCI or without. And if you look at all of this, the p-value for interaction is all negative, stating that complex PCI and non-complex PCI, no matter what, that the newer generation DES significantly lowered the risk of death MI and of course, stent thrombosis, really, really important. These were adjusted risks, and you see that they look really, really good for these randomized studies. And then along came this really, really excellent study as well in JACC. This one was long-term outcomes in women and men undergoing PCI. Here, they looked at men versus women. We focused only on our female patients. So they looked at the 21 randomized studies and they looked at bare stents, first and second generation DES, and they had follow-up out to 5 years. And what they showed in a very, very nice way is that in the 9,141 female patients from 0 to 1 year compared to men, women experienced a much higher rate of cardiac death, ischemia-driven TLR, or myocardial infarction. And you see that here, the p-value being positive. And the same thing, the overall p-value in terms of these important outcomes, they were higher. The 5-year MACE rate was 18.9 versus 17.7 in women versus men. And the overall p-value was much higher. And this is really important because most of this differences was seen in that first year. And if we then adjust this for the 5-year outcome of MACE and in multiple models that includes important covariates, trying to figure out whether or not there is an important difference, we start to see that the p-values are coming up for these important death, MI, ischemia-driven revascularization. So when you compare men to women, women exhibit a lower overall burden of atherosclerosis, shorter lesion lengths, reduced target lesion complexity, reference vessel diameter smaller, but worse outcomes at 5-year follow-up. And this is important because I think trying to understand the paradox of why is it that this is happening, Michelle O'Donoghue wrote a very, very important editorial about this, understanding the sex paradox after percutaneous coronary intervention, trying to understand how is it that with these lower burden of atherosclerosis, shorter lesions, these women still have a higher rates compared to men. And then, of course, as we begin to get more and more into the complexity of the patients, especially women who are at high risk for bleeding, we know that right off the bat that female gender is an important risk factor for bleeding, and that most of the drug-eluting stent studies have excluded high bleeding risk patients. These investigators, the Leaders Free trial, they included everyone who had ever been previously excluded. And as a result, for the first time, we go above 20% women to 30% women in the population of the patients who were evaluated in the Leaders Free trial. And to remind you all, in this trial, in Leaders Free, the randomization was between a bare metal stent versus a drug-coated stent, which was a Biolamus A9 eluting polymer-free biofreedom stent. And they showed a reduction of TLR as well as a reduction of the ischemic endpoints of death, MI, and stent thrombosis with the drug-coated stent for the overall population. So we wanted to be much, much more clear on this important secondary analysis of Leaders Free, the sex-based outcomes. So we undertook this evaluation of the 738 women compared to the 1,694 men in this important study, as we found that very importantly, as you can see here, there were no sex differences in the ischemic outcomes of patients with high bleeding risk comparing men to women. And you see that it's crossing the line of unity, women being a little bit higher, but the adjusted risk is no different. And the p-value is absolutely flat for that safety endpoint of cardiac death, MI, and stent thrombosis, as well as TLR between men and women. This is really important. But when we look at the important bleeding outcomes, here's when we start to see a greater early and major bleeding, especially vascular access bleeding complications in the female patients. And you can see that right here, where women, especially if they have a femoral approach, take a look at the women with a femoral approach. Pretty much in the femoral approach, you are seeing a very important, so whenever possible in a high bleeding risk patient, we should be looking at the radial artery access for women. And I know that many are very nervous about going into the radial artery for women because of the tortuosity and the spasm and everything else that women have more commonly. But take a look at these data about the bleeding complications, especially for women with BARC 3 to 5 bleeding, radial versus femoral. Really hugely important differential. Also, it's important that most of the bleeding was vascular bleeding. And that's important because everyone here received only 1 month of dual antiplatelet therapies. And then, of course, if you look at the 2-year mortality in women and men following a major BARC 3 to 5 bleed, both men and women had to experience a worse mortality. So we have to avoid bleeding, whether you're a man or a woman. And importantly, really importantly, is the incredible impact of access site-related bleeds and high mortality in these women. So we absolutely, when there is a BARC 3 and 5 bleed, if there anything we can do to avoid this important complication. And we do have to, in PCI, think about this bleeding risk. And the reason for it is this multifactorial reason. In peri-procedural pharmacology, the access site anatomy, platelet biology, and the body mass index, all of it working against our female patients, especially when they're older. And it's really important to think about this as contributing factors in higher risk of bleeding in our female patients. And if we look again of the common femoral artery diameter measurements between men and women, we might have the answer right then and there. If you look at the TAVR trials in the CAF-PCI registry, you can see that women always have a smaller femoral artery diameter. And this is where we have actual data in large numbers of elderly women. But the sheath sizes and the device sizes don't come in pink or blue for men and women. We really have to be very, very careful about this. And it was really not until the SAFE-PCI study, which was a registry-based randomized trial comparing radial and femoral artery approaches in women, where we began to start to see the differences here. Now, I showed you in the previous studies, and it was still, unfortunately, difficult, despite the fact that this registry trial for the first time was able to get a lot of patients. At the end of the day, the study was stopped early because of the low enrollment and because of the low event rates. And in the end, we had about 600 patients to evaluate. And if you look at the important differences here, the access site crossover from radial to femoral in the radial arm was higher. Obviously, these are all women. There are no men or women. This is only women in this study. And the most common reason to convert from radial to femoral was to complete the procedure was radial artery spasm. And the interactions were not significant for ACS versus non-ACS. And you see that the vascular bleeds with radial were lower than with femoral. So really showing an important benefit, even though this did not reach statistical significance, is quite small. And we've seen a lot of other data that supports this finding. And the efficacy endpoints, as far as the total randomized cohort, all of them, you saw that BARC 2, 3, 5 bleeding in radial was much lower than in femoral. And we did see some more procedural failure in the radial artery. Of course, the trial was stopped early, lower than expected event rate. The radial approach didn't significantly reduce bleeding, but the trend was there. Access sites crossover occurred more often in these women assigned to the radial access. I think in the end, ladies and gentlemen, there's no question that we have to take into account multitudes of risk factors for women, understand their biology, the differences in the biology of the disease, understand the anatomical differences, and then, of course, the fact that when women present for a PCI or a STEMI, or non-STEMI or stable coronary artery disease, they will always come with more comorbidities compared to their male colleagues. And when you look at the results of revascularization with men versus women, you're getting some mixed results based on the study design, population, etc. But no question that women have a higher risk, they have higher adverse events, and in the end, they are experiencing a higher mortality. There's no question that they're at a higher risk for bleeding events, and we must at all times avoid and look for strategies that avoids and averts bleeding. Women, at the end of the day, are underrepresented in clinical trials. And until we all do our job to enroll more women in our clinical trials, or design studies just for women, or design studies where the inclusion criteria bring more women into the clinical trial, we will never find the answers. And it's really important that both device and antithrombotic regimens that we currently have up to now are in mostly male populated studies. And so it's important for us to continue to dig into the sex differences every single time that a trial comes out. So these sex-related factors that do exist and contribute to worse outcomes still yet need to be elucidated. And I think it's really important that we continue to enroll more and more women in clinical trials to better understand this biology. I think when we see that you can and will be successful in enrolling studies and answering questions that are really important to our female patients by enrolling female-only patients, you will get a lot of answers to the questions. I want to thank you again for having me, and I look forward to a very, very bright future on revascularization therapies for our female patients with cardiovascular disease. Thank you for having me.